Systemic effects of corticosteroids, mechanisms and clinical implications. Corticosteroids produce widespread systemic effects beyond their anti-inflammatory actions through impacts on metabolism, immune function, and endocrine regulation. Understanding these effects and their physiological optimizing therapeutic use and minimizing represent a critical class of hormonal medications that mimic the natural steroid compounds produced by the adrenal glands. These substances exert profound effects across virtually every organ system in the body, orchestrating responses to stress, modulating immune function, and regulating fundamental metabolic processes. When administered as medications, corticosteroids can deliver therapeutic benefits for inflammatory and autoimmune conditions. Classification and types of corticosteroid activity creates a complex pharmacological profile that demands careful clinical consideration, and mineralocorticoids operate through distinct mechanisms to maintain physiological equilibrium. Glucocorticoids primarily influence carbohydrate metabolism, protein breakdown, and inflammatory responses, while mineralocorticoids regulate sodium retention and potassium excretion to maintain fluid and electrolyte balance. Most therapeutic corticosteroid medications target glucocorticoid receptors. Metabolic mineralocorticoid activity persists with certain agents, particularly a higher administration, triggers substantial alterations in how the body processes when considering which and generates corticosteroid to employ for these medications. Promote the breakdown which adverse effects into amino acids might experience, glucose, shifting the body's nutritional priorities toward increased blood sugar levels while simultaneously promoting fat deposition in specific regions. Patients receiving systemic corticosteroids frequently develop hyperglycemia, which can manifest as new-onset diabetes or exacerbation of existing glucose control problems. The metabolic effects include increased hepatic glucose production, reduced insulin sensitivity, and promotion of lipolysis, creating a metabolic state that resembles an exaggerated stress response. Key points: elevated blood glucose levels through hepatic gluconeogenesis and reduced insulin sensitivity. Immunological and inflammatory central fat redistribution producing one of the primary reasons corticosteroids around the face and upper back involves their powerful ability to suppress inflammation leading to muscle weakness and potential sarcopenia. These medications function by modifying the number with elevated triglycerides and function of white blood cells, reducing the production of inflammatory mediators and decreasing vascular permeability. While these properties prove therapeutically invaluable in autoimmune and inflammatory conditions, they simultaneously increase vulnerability to infections ranging from common bacterial pathogens to opportunistic organisms normally controlled by intact immunity. The degree of immunosuppression correlates with dosage and duration of therapy, creating a therapeutic dilemma where higher doses provide better anti-inflammatory benefit but at the cost of greater infection risk. Key points: reduced lymphocyte counts and impaired T-cell-mediated immunity. Endocrine system alterations, antibody responses, and compromised vaccine effectiveness. The hypothalamic pituitary adrenal axis represents the master regulatory system controlling endogenous corticosteroid production with atypical organisms, including corticosteroid administration, provides negative feedback to this system, suppressing the release of corticotropin-releasing hormone and adrenocorticotropic hormone, ultimately reducing the body's own cortisol synthesis. Prolonged suppression can result in significant adrenal insufficiency that persists long after medication discontinuation, creating a clinical syndrome characterized by fatigue, weakness, hypotension, and potential life-threatening metabolic derangement. The timeline for recovery varies among patients, but therapeutic corticosteroid exposure exceeding 2 to 3 weeks carries meaningful risk for clinically relevant axis suppression. Additional endocrine consequences extend beyond adrenal function to affect thyroid metabolism and fluid homeostasis and reproductive hormone balance. Corticosteroid exposure produces significant cardiovascular and fluid hormone metabolism disturbances, potentially destabilizing thyroid-dependent individuals requiring replacement many corticosteroid preparations. The metabolic effects on glucose control mentioned previously reflect leading to direct glucocorticoid accumulation and secondary hypokalemia requiring vigilant monitoring and pancreatic beta cell function. Beyond electrolyte effects, corticosteroids increase vascular tone, promote atherosclerosis, and trigger a hypercoagulable state through effects on platelets and clotting factors. Long-term corticosteroid recipients face substantially elevated cardiovascular disease risk, creating particular concern when prolonged therapy proves necessary and bone chronic complications. Key points: the skeletal system experiences sodium retention and vascular reactivity corticosteroid administration, hypokalemia and metabolic alkalosis from urinary potassium wasting, reduce bone formation by suppressing osteoblast activity while simultaneously increasing bone resorption through osteoclast accelerated atherosclerosis. Additionally, and coronary these medications disease. Impair intestinal calcium absorption and increase urinary calcium excretion, creating a calcium balance that favors bone loss. The combination produces accelerated osteoporosis that can manifest within months of therapy initiation, with fracture risk elevated substantially even at moderate corticosteroid doses. Vertebral compression fractures represent a particularly concerning complication, potentially occurring without recognized trauma in vulnerable patients. Beyond bone quality deterioration, corticosteroids produce muscle weakness through direct effects on myofiber function and exacerbation of protein manifestations. Corticosteroid-induced myopathy represent a notable concern in corticosteroid-treated particularly in patients already compromised by underlying conditions. These medications promote weakened muscles and fragile bones, impair mucosal protective mechanisms, risk and reduce serious blood flow injury, collectively increasing receiving prolonged corticosteroid therapy. The immunosuppressive properties also allow opportunistic gastrointestinal infections to establish themselves more readily in affected individuals. Mood alterations represent another significant systemic effect, with patients experiencing neuropsychiatric manifestations ranging from mild emotional lability to severe psychiatric symptoms, the eyes and skin including frequently display corticosteroid-associated changes reflecting the both local and severity of psychiatric effects correlate cataract with formation represents a well-documented consequence of prolonged unpredictable outcomes that require careful psychological monitoring, the posterior lens capsule and potentially impairing vision substantially. Intraocular pressure elevation occurs in susceptible individuals, necessitating ophthalmologic monitoring in at-risk populations. Dermatologic manifestations include skin atrophy, easy bruising from compromised collagen and blood vessel structural integrity, and acne exacerbation. Some patients develop striae to minimize systemic adverse and characteristic Cushingoid facies reflecting extensive systemic effects has prompted development of clinical changes can profoundly impact quality of life and body while minimizing harm. Particularly in younger patients requiring extended corticosteroid dose for the shortest possible duration. Titrate toward discontinuation when clinical conditions permit, and consider alternative therapeutic approaches when corticosteroids are not absolutely necessary. For patients requiring extended therapy, prophylactic measures including bone protective agents, gastric acid suppression, calcium and vitamin D supplementation, and cardiovascular risk reduction prove essential components of comprehensive care. Key points: minimize dose and duration through careful clinical judgment and periodic reassessment. Implement bone protection strategies with bisphosphonates balancing or other benefit against in high-risk patients. Systemic corticosteroids represent extraordinarily potent anti-inflammatory and immunosuppressive agents capable of rapidly improving serious regarding infection signs and autoimmune medication adherence and lifestyle modifications. Their widespread physiological effects create substantial risk for adverse consequences affecting virtually every organ system when employed in therapeutic doses, particularly during extended therapy periods. Clinicians must maintain vigilant awareness of these potential complications while working toward treatment goals, implementing preventive strategies, monitoring for early manifestations of harm, and regularly reassessing whether continued corticosteroid therapy remains necessary. Thank you for watching. The therapeutic value of these medications MedMind in appropriate clinical contexts remains undeniable. Like and subscribe, yet their use demands evidence-based risk-benefit analysis and comprehensive patient management that extends far beyond simply prescribing the medication.